So good afternoon, everybody. Now you get to hear from me. So that's good. And I also heard that it might be siesta time, so hang in there with me. A quick announcement, the lectures are being recorded, and you can view them by webcast if you go to the IPOKRaTES website, and the password is IPOKRaTES. No need to enter a username or anything like that. So, my name is Cammie Martin. I'm a neonatologist from Boston, Massachusetts. My home base is there at Beth Israel Deaconess Medical Center, and I did my fellowship there as well at Harvard Medical School Children's Hospital. So what I'd like to talk about today is the postnatal intestinal adaptation of the premature infant and what may be the implications of this adaptation for short-term morbidities as well as long-term outcomes. So I'll speak of the fetal development of the gastrointestinal tract, including the role of amniotic fluid. I'll review the postnatal processes in intestinal development and its role in further developing the intestinal barrier and immune defenses. Then I'll discuss the impact of prematurity on that intestinal development and what are the clinical implications of altered intestinal development and altered immune defenses. So let's begin with the fetal development. And I don't have my image for some reason. I hope that's not going to be true of everything. Okay, so that's okay. So this was an image that you had seen before of the gastrointestinal tract. So when fully mature, the gastrointestinal tract, as Dr. New introduced, is your largest defense barrier. It's also one of your largest immune organs. It begins development very early, and it continues well after birth and into childhood. There's three main segments to the intestinal tract. You'll have the non-specific barrier defenses. That first layer of defenses, mainly in the lumen, is a series of physical and chemical barriers. It provides an acidic environment to potential foreign antigens. It has digestive enzymes that break down these antigens into smaller molecules. Bile salts are present, the mucus layer, our peristalsis that helps move along any bound IgA antigen complexes outside and prevent translocation. Antimicrobial peptides produced by specialized cell of the epithelial layer and that maintenance of the tight junctions, that cell-to-cell adhesion. The epithelial cell layer has specialized cells, the goblet cells that produce the mucin, Paneth cells that produce the antimicrobial peptides and defensins and other defensins, and the M cells, which are your antigen-producing presenting cells, takes that antigen-antibody complex and brings it in so that the innate and the adaptive immune system within the lamina propria can correctly handle that potential pathogen. But really, it's a balance during that programming of being able to appropriately tolerate some antigen influence as you want to, but also to be poised and ready to mount an inflammatory attack if you need to. But it's a balance that must be maintained because a balance in one way or another may then propagate further injury or disease. So this development begins very early. The specialized cells, the advanced structural components, and the elements of the innate mucosal immunity are present well, as you can see, most of the elements before the 20th week of gestation, and a few more just after that. And that continuing influence and development of those specialized cells and functions are as a result of what is present in the amniotic fluid. This is actually a proteomic analysis of the amniotic fluid where over 500 different proteins were detected. If you probably did something similar to the breast milk, you would find very similar proteins and compounds there, but you have hormones, growth factors, other nutrients, modulators of immunity and inflammation, and those that work with cell growth and differentiation. So this amniotic fluid, the premature infant's being exposed to on a daily basis. This was done at 16 to 18 weeks, this analysis. And as we also heard, the fetus swallows 450 to almost a liter a day of amniotic fluid. And when that flow is interrupted, there is disease in the intestinal tract. And so there's animal models where they ligate, or they were able to inhibit the flow of amniotic fluid in the gastrointestinal tract. And there were distal intestinal aberrations as a result of that, deficiencies in absorption or further growth and development. So in the postnatal world, after the baby's born, I'll review some of the things that happens with the term gestation and otherwise healthy, and then we'll compare that to the preterm infant. So the two major environmental influences that continue the development of the intestinal tract are the diet, preferably breast milk, but also formula we must consider, and the bacterial colonization. So that's a critical element in the development of the intestinal tract, is the host environment, the host's interaction with the environment, and the bacterial colonization that lays hold and takes home into the intestinal tract. Without that, you won't be able to further develop, especially your innate immune defenses. So this is an image from a study of gnotobiotic mice. It's one of my favorite demonstrations of this, where in this sterile environment, you have poorly formed germinal center in the spleen. You have poor presence of CD4 in the lamina propria, and decreased amount of intestinal IgA. But when exposed outside of that sterilized environment and allowed to interact with the indigenous organisms and colonization of the gut, you begin to see these germinal centers form, increase CD4, as you see with the staining, and increase IgA. So it's critical that they have that interaction. It's what kind of interaction that we'll talk about a little bit later that becomes very important. So there's been many proposed benefits of the microbial host interaction, and proposed is probably too soft. There's actually pretty strong animal evidence that this is the benefits of that microbial host interaction. It maintains the integrity of the mucosal barrier. It reduces the permeability, it increases mucus production, it strengthens those tight junctions, and it helps inhibit the bacterial translocation. There's also actually a competitive interaction between the type of organisms, so that the more commensal-like organisms will compete against the pathogenic bacteria for binding sites. It activates, as I mentioned, the intestinal immune defenses by increasing fecal and mucosal IgA, and we heard a little bit about producing short-chain fatty acids, and it modulates the intestinal inflammation. It modulates, and we'll discuss that a little further, about the production of both the pro-inflammatory and the anti-inflammatory cytokines. Here was one review that discussed that microbial host interaction through TLR, or toll-like receptors. So when you have traditionally what they call the commensal bacteria interacting with the toll-like receptor on the basal surface of the epithelial cell, this signaling allows for homeostasis of the intestinal surface and robust repair in response to injury. If you have a disruption of that interaction between the bacteria and the toll-like receptors, either from the distal signaling or inappropriate bacteria or not the right bacteria to promote this response, you'll get enhanced sensitivity to injury and a diminished capacity to induce repair. Here's another illustration of how bacteria interacts with the gut to regulate inflammation. On the right here, a schematic about how a pathogenic bacteria may promote inflammation, and to the left, what commensal bacteria may do to inhibit inflammatory markers in cytokine production. NF-kappa beta, a nuclear protein that when translated, inflammatory genes are switched on and you get an increase in the pro-inflammatory cytokine production. This process is inhibited by I-kappa beta. Pathogenic bacteria allow for the degradation of the I-kappa beta, freeing up the NF-kappa beta to do its job. Other bacteria are known to actually inhibit this degradation of I-kappa beta, and therefore preventing the turning on of these inflammatory genes and inflammatory cytokine production. So it's that balance between what your microflora and your microbiome look like that will determine what your intestinal tract is going to be doing in the production of inflammatory cytokines. We'll hear more. I'm going to touch upon the microbiome a little bit. You'll hear a lot more from Dr. New. But there's many different environmental exposures that may modulate what your microbiome looks like. Breast milk offers the best microbiome colonization with an increased amount of commensal bacteria, especially Bifidobacterium and Lactobacillus, when compared to formula especially, which seems to predominate in Enterococci, coliforms, and Clostridium. The route of delivery, C-section versus vaginal, influences the microbiome, as well as hospitalization in the indigenous organisms, the use of antibiotics that we'll speak to, and also prematurity that we'll also speak to in more detail. So your environmental exposures and your nutritional inputs are very important in dictating the balance of this microbiome. And so there's been many hypotheses, not only in the NICU literature, neonatal literature, but also in later childhood and adulthood, is this abnormal bacterial colonization patterns, are they important in disease development, especially, again, kind of what we just discussed, its role in modulating immunity and inflammation. So what happens to our babies in the NICU? Well, we all know they're extremely premature, and it's been shown that they have decreased immunoglobulin levels, decreased production of digestive enzymes, decreased production of mucus, and a dysfunctional peristalsis. So that whole first line of defense that I mentioned is already diminished and impaired before you even get to the epithelial layer. And then onto the epithelial layer, delayed feeding and other practices promote villus atrophy. Decreased production of digestive enzymes, decreased production of mucus, and decreased production of peristalsis, a vicious cycle. Medications and practices that we routinely perform in the NICU, like H2 blockers we heard about, decreasing gastric acidity. Vasopressors and indocin, reducing the amount of blood flow to the gut. And even sedatives and paralytic agents that decrease peristalsis. So medications that we may not have initially thought impacted so much of their innate immunity and inflammation or even gut development, but it does. This is, wanted to highlight a few of the practices now and sort of where the data is coming from to suggest that this may alter the postnatal intestinal adaptation in the premature infant. This is data from the ELGAN study, and you'll hear me refer to that quite frequently. The principal investigator is Alan Levinton. He's a neuroepidemiologist at Boston Children's, and his primary reason for this prospective cohort study was to actually look at inflammation and the risk of white matter injury. And I was a part of that study with Beth Israel Deaconess Medical Center. There were 15 NICUs across the United States. Over 1,500 premature infants were enrolled from 2002 to 2004. So in addition to the clinical data, also a lot of biological samples and other data were collected as well. And my focus has been nutrition and growth, so I started to look at the data regarding this. And so here what you see is that along the x-axis is gestational age in weeks, and the percent of infants with any enteral feedings. So we've talked about trophic feedings and at what point does babies get to full enteral feedings and how patterns may not have changed over time despite what we know about the importance of trophic feedings. And unfortunately, the ELGAN data, which I'll say more of, sort of reconfirms that. These bars are at day of life 0, 3, 5, 7, and 14. So for example, in a 24-weeker at day of life 3, about 15 to 18% of infants were receiving any enteral feedings. So not 10 per kilo, 20, just any. So that's a fair amount that's still at day 3, which may be too late, even in these young ones, are not receiving any enteral feedings. Even for our older infants, by day 3 in a 27-week infant, 40% were receiving some enteral feeding. Therefore, 60% were still NPO, not receiving any enteral substrate. So a very prolonged period of no enteral substrate or anything into the gut. So what are the consequences of not having that enteral substrate? I think there's several groups doing really nice piglet studies and prematurely delivering piglets and treating them just like we treat them in the NICU. will make them NPO or slowly gavage feed them or rely on TPN. So they're able to really look at that postnatal intestinal adaptation. So these are the next several slides are coming from those piglet studies. Apoptosis in the villus cell, you can see that by the time at 48 hours of PN alone and no enteral substrate, in the villus and the crib structures, you're seeing apoptosis. So that's by 2 days. Also by 2 days, you're seeing a decrease in cell proliferation. So that normal turnover, cell proliferation and mucosal growth is also inhibited or stunted. And then also with the reliance of PN and no enteral substrate, you're also reducing the amount of blood flow to the gut. So multiple changes within the first few days of not having any enteral substrates, you're already starting to see the consequences. And I think just listening to the talks earlier and knowing kind of what I'm going to speak about in the next couple of days, I think we need to really start thinking about immediately what we're doing for nutritional care. And so people talk about the golden hour of lung development or prevention of IVH. I think we should start talking about the nutritional emergency and the golden hour of a premature infant nutritionally as soon as they're born and after they're born, and what should we be doing? This is the study about the H2 blockers and necrotizing enterocolitis using the National Institute of Child Health Development cohort from 98 to 2001, low birth weight infants, 1 to 3 case control. They had 3 controls for every case of NEC. So here is what we call the multivariable model, where they looked at the exposure in relation to the outcome. And everything else in this model here is to help control for those confounders, for those things that might be influenced for both the exposure and the outcome. And even controlling for gender, outborn versus inborn, level of illness as much as they could, and the administration of postnatal steroids. Receipt of H2 blockers had an increased odds of 1.71. 71% were likely to get necrotizing enterocolitis than if never receiving any H2 blocker. So this has decreased in the use of in our NICUs. It was almost too easy to give it because of the rationale earlier, and that's another thing. It's just kind of when you reevaluate that evidence, just the cultural change that it takes. On our PN forms, we actually had just a checkbox whether you wanted, Zantac added or not. It's way too easy. So finally, we just completely removed that option from the PN forms. Is this changing or altering the intestinal microbiome? Antibiotics, another study from the NICHD, same cohort years, but they did this in extremely low birth weight infants. What's impressive, and I think we see this in our, I think we all can reflect on this, is that 90% of all babies received some antibiotics. 53% received a prolonged course greater than 5 days. And not necessarily because of a positive blood culture, just the concern of a potential infection that we all have while they're in the NICU. While adjusting for these other factors, to have the odds of NEC went from none to 1.41 for the receipt of any prolonged antibiotics. It's also increased for every day that you receive an antibiotic as well. So again, is it by way of altering the intestinal microbiome, where the loss of that normal interaction between commensal organisms in the epithelium is no longer there, disrupting that protection that the infant may have against those stimulators of necrotizing enterocolitis, decreasing the resistance to any damage and the ability to repair afterwards, and then the increased translocation, bacterial translocation, causing NEC and perhaps sepsis or other concerns. So the same influences of the full-term infant on the microbiome apply to the premature infant, except that I think they're magnified. We talked about the delayed feeding, the broad-spectrum antibiotics, the formula feeding, the transition to some enteral substrate, but also balancing that to wanting to prefer to give breast milk, and of course the prolonged hospitalization. So there's many studies, or evolving studies, about the microbiome and the risk of NEC. This is just one of several that are out there. This was by Erica Claude's group out in Chicago, where I think reflects the theme that we're seeing over and over again, and that is those NEC infants have a decreased diversity in their microbiome, And they also get, even with longitudinal data, kind of a blooming of this proteobacteria class, the largest class of bacteria, but lots of gram-negatives and other pathogens, and they have an increased representation of that. But when I was delivering this talk or thinking about this talk, I also don't want you to come away thinking, well, that means the control infants were doing okay and their bacterial colonization was okay. And in fact, if you look specifically at the outputs of what the control infants are being colonized with, they're pretty scary looking too. And so just a quick antidote, as I'm looking at the microbiome back home, and I'm collecting stools, and I'm working with somebody who does this back home, and we're going to look at neck and control, like a lot of other people. So I give him some samples to analyze, and he calls me. He says, you got to call me. This is crazy. I think, I know what's going on. I'm like, really? Wow, we've never figured out neck, but okay. So I call him back, and he said, these babies are colonized with the most pathogenic organisms that I see in my adults' inflammatory bowel disease. He goes, that's why they're getting neck. And I said, Bruce, that's his name. I said, Bruce, you have the control infants. So even in the control, what's being colonized is actually pretty scary when you see the results in the microbiome reports. So it goes back. It's a multi-hit hypothesis. It's not just the microbiome, but also maybe looking at why some infants are able to protect themselves against that and others aren't. And the acute short-term morbidity may also give us some insights about development and what we need to promote in our practices to help allow every infant to be able to compensate in their postnatal adaptation a little bit better. So clinical complications of altered development. So here's another image, and just to summarize. So decreased pH, decreased peristalsis there on the right, an altered microbiome, altered tight junctions, decreased enzymes, decreased defensins, decreased IgA, and a decreased mucus production. This allows increased antigen delivery to the innate and adaptive immune responses that may also differentiate differently based on the microbiome or the bacteria they're exposed to, and increased cytokine production. So the question I want to raise or talk through is that maladaptation and development, that altered immunity and dysregulated inflammation, does that put us at risk for local intestinal injury, which then is that a driver for some of the illnesses that we see in the NICU? Or even more specifically, can a milieu, even without neck, continue to drive, because of this chronic inflammation, to other chronic inflammatory diseases that we see in the NICU? So the gut as a motor of critical illness. So a concept that's actually been, I think, a little bit more developed in the adult population, but you have barrier dysfunction, an altered microbiome, altered immune development, and this chronic production of inflammatory mediators. So a quick study in the adult ICU, looking at those that were admitted to the ICU with SEERS or systemic inflammatory response syndrome based on their levels of CRP, and looking at their microbiome of those that were in this inflammatory response syndrome and those that were normal. They did see differential in the amount of, in purple, sort of the traditionally thought commensal bacteria versus those that are a bit more pathogenic, that were more common in those that had elevated CRP levels and were more critically ill in the NICU. So we'll talk more about, no, these were also in the ICU, they just did not have elevated CRPs. Yeah, but your point well taken. Antibiotics mess up the microbiome and the colonization, and we use them all the time, and not so discriminately do we use them. So it's a tremendous confounding factor. So another image to look at, okay, does this translocate, does this intestinal inflammation drive local as well as distal injury? So let's talk about the first of those three steps there in that longitudinal scheme, the intestinal epithelium and its response to organisms, and how do they respond? So the immature epithelium definitely has a hyper-exaggerated or exaggerated pro-inflammatory response when encountering both pathogenic and commensal bacteria. So think about that when we think about the probiotic literature as well. So this was a study And these are mature cells, immature cells, and cells that were taken fresh at surgery from infants with necrotizing enterocolitis. They did mRNA gene expression levels of IL-8, the regulators of the production of IL-8, as well as the negative regulators. And you could see that compared to mature epithelial cells, intestinal cells, the immature ones have greater production of IL-8, greater production of those signals that lead to the production of these inflammatory cytokines, and a decrease in the negative regulators. Another study, similar theme, also by Erica Claude, that looked at Salmonella and E. coli on adult cells and on fetal cells. And again, compared to the mature or the adult cells, the fetal cells have an exaggerated response of IL-8 production when encountering those pathogens. So the microbiome is important, the organisms are important, but the way the immature epithelium or intestinal cell reacts is also important. She went on to say, well, could it be that inhibitory kappa beta? Is there something different about that molecule in the mature and the immature? And when she's looking for the protein, she does see that the fetal cells have decreased I kappa beta alpha, just one of the subunits in the epsilon here. So going back to the schematic and paying attention now that for this part where it's supposed to stop any inflammatory genes from switching on, our immature babies perhaps have a developmental reduced expression of I kappa beta, and therefore the genes are not turned on, rather they are switched on, and they have this continuous production of increased cytokines and inflammation. What's the cytokine or inflammatory story for necrotizing enterocolitis? Well, that literature is quite robust. A lot of studies have shown that yes, indeed, in severe intestinal injury, there are increased levels of these inflammatory proteins and biomarkers. This is again from the LGAN data, which has been submitted. And we looked at severe intestinal injury, both necrotizing enterocolitis that needed surgery or even isolated perforation. We looked across, this was for the, we did this on weekly levels, day 0, day 7, and day 14 of life. So this is just saying if you have it on one day, elevated levels on one day or greater than 2 days. This is a truncated list. We looked at many proteins, but you see that for both categories, you do have systemic elevation compared to infants who did not experience a severe intestinal injury of CRP, serum amyloid A, IL-6, and IL-8. So there is, from a local process to a systemic circulating release of these inflammatory proteins. What do we know about the development then of NEC? So again, the hypothesis is the intestinal development and gut, and that inflammation that we see locally, and now I just showed you systemically in severe intestinal injury, can that account for other disease processes? And we'll talk about the neurodevelopment now. So this is also LGAN data where we looked at long-term 2-year outcomes of motor and cognitive, or cognitive motor function as a result of having necrotizing enterocolitis or not, but also we looked at whether you had bacteremia or sepsis or not. So if you look at here, this is no bacteremia, no NEC, medical NEC, and surgical NEC. So consistent with previous literature is that medical NEC alone does not necessarily increase your risk of poor outcomes for your mental developmental scales as well as your motor developmental scales. What I always like to orient people, especially non-neonatologists, is that those rates are still a quarter. 25% of our cohort have long-term neurodevelopmental disabilities as the control, as no NEC or sepsis. Surgical NEC, those numbers jump to 40 to 48%. And with the addition of any sepsis, even medical NEC is now starting to increase in the amount of poor neurodevelopmental outcomes, as well as the surgical NEC with a high increase in the rate of cerebral palsy. So severe NEC is associated with CP and neurosensory impairment, and this was another study with the NICHD that's corroborating that as well. It was actually done earlier, where your CP surgical NEC was 24% of their cohort versus 12% in the medical NEC or no NEC. And then you see the mental developmental index and the motor developmental index also much higher in those with severe intestinal injury. This is after controlling, again, as best as you can with epidemiologic data, for any potential confounders that may also impact long-term neurodevelopment. So there does appear to be an independent risk of neck or intestinal injury to long-term neurodevelopment. I don't have the data here, but similar findings are being shown for intestinal perforation alone as well. So there seems to be a clustering of neonatal diseases, and is this severe intestinal injury a potentially common link? So we looked at that, the odds of having brain injury, retinopathy of prematurity, chronic lung disease, or bacteremia, early or late, if you had one of these conditions. And it's the intestinal injury, defined as the same way we defined it before, and that was surgical necrotizing enterocolitis or intestinal perforation. Having a severe intestinal injury increased your odds, these are odds ratios, of having white matter injury, 2.3 odds, 3.1 of retinopathy of prematurity, 3.7 times more likely for BPD, and then late bacteremia, 2.1, or I guess that's over there for the lungs. So the intestinal injury does seem, if you have that, you are more likely also to have other systemic illnesses or morbidities while in the NICU. So one explanation possibly could be, well, is this just immaturity? Are we just showing that you're just younger and more likely to get everything else? But when you adjust for gestational age, this association does not go away. So what is happening here that we see these clustering and perhaps around intestinal injury? Well, one hypothesis could be, well, is there a common antenatal or early neonatal characteristic that's similar and important for all disease processes? Or is there an antecedent to neck that influences the risk of other disorders? For example, bacteremia, or is there a therapy like chronic ventilation and therefore chronic lung disease? So are we just seeing these relationships by association? Well, one thing you could put here is perhaps it's that intestinal injury, inflammation and bacterial translocation. But something that concept I'll develop further in additional talks is you can also put the theme of this whole conference, and that's nutritional impact, nutritional delivery, its impact on immunonutrients, and that impact on all of these processes because of the increased inflammatory state our babies are in, and how our practices, and perhaps lack of certain practices, propagate that cycle. So is there an early exposure that is unique to the premature infant with multiple downstream physiologic effects? And we'll talk more about that as the days come. So conclusions, implications, and potential strategies. Well, I think the development of the intestinal innate immunity begins in utero with exposure to the amniotic fluid. And this continues with postnatal exposure to exogenous diet and community organisms. And with that altered early intestinal development, the gut can act as a motor of critical illness by initiating and propagating an ongoing systemic inflammation. And ongoing being key, and I'll show you some more evidence tomorrow, that this is a chronic state that these babies may be in. And we have to ask how we can take these findings to the bedside, promote that optimal postnatal development from the moment the baby is born. Waiting several days may be too late. I think the role of the gut has been largely underplayed. But just as I said earlier, that as we look and consider mediating all the other morbidities, we also have to think about intestinal development and perhaps through nutritional strategies. So you're going to see more of this figure as I keep coming back to it. But today I wanted to concentrate on that postnatal intestinal adaptation. Showed how nutritional practices, H2 blockers, antibiotics, delayed enteral feeding, other medical practices as well, with the antibiotics, for example, and the H2 blockers, how they come together and alter that postnatal intestinal adaptation in multiple ways, primarily through perhaps the microbiome, an altered microbiome. Its role and how that then alters immunomodulation, helps propagate a chronic ongoing systemic inflammation, how that's been shown to be related to neck and intestinal injury, but how also that link is now, this link is now beginning to be evident in other morbidities that we see, including the brain, the lung, sepsis, and its consequences on neurodevelopment. So what can we do now? I mean, this is, we were saying earlier, this is kind of the challenging part, is this is starting to come together as we starting to understand how these processes are important for our infants, but what tools do we have to the bedside? And I think that's obviously continues to evolve. But, in rounds, I think you can think limit duration of MPO status. Think again why you're not feeding the infant, and how what was said earlier about all the things that we traditionally have used to say that that baby's too sick to feed really hasn't been substantiated. And instead of being afraid to feed, we should be afraid not to feed. Encourage the delivery of human milk. Limit the medication exposures that are known to alter things. And what are things that we can pursue or we're pursuing now? Well, you'll hear more about prebiotics, probiotics. Perhaps instead of cow milk-derived fortifiers, do we work on human milk-derived fortifiers? Tomorrow I'll speak about the PUFAs and long-chain fatty acids as immunonutrients. And there was a period of time where synthetic substrates were actually discussed a lot. I don't hear so much about it now, but as a potential mean to bridge the period of MPO to substantial enteral feedings, I think with donor milk banks and other things, other units have found other ways to immunomodulate during that critical period. But we also talked about trophic feedings, and it helps, but at the volumes that we're receiving won't help for a very long time. Burren in one of the piglet intestinal models really showed that it took 40% of your full enteral feeding. So if you say that's about 120 ml per kilo, 40% would increase mucosal mass, but you needed about 60% to maintain proliferation and growth. So trophic feeds is a start, but we also have to get further beyond those volumes. All right, thank you. Questions? Yes.
You're talking again about premature neck. I mean, neck in premature babies.
Yes.
Of neck.
In a term infant. Yeah, you'll hear more about that in the last day when we talk about necrotizing enterocolitis. But yeah, as discussed before, probably a completely different process in why term infants get necrotizing enterocolitis. Been associated with congenital heart disease and maybe other factors that are reducing intestinal blood flow.
I know that we will discuss also about probiotics, but I would like to know which is your personal position about probiotics used in preterm newborns.
Okay.
Do you use in your
Yes.
unit?
No, we do not
Routinely?
use
Okay.
probiotics in our NICU. Again, obviously, you can tell by the way I position this talk that I think it's important and the microbiome is important, but I am concerned about the extremely premature infant in that cohort of infants, because also what you just heard me say is that their intestinal development is aberrant. Their tight junctions are not intact. Even in response to commensal organisms, some of them will respond in a very inflammatory, hyperinflammatory way. And when you look at the probiotic literature, not really powered to show for sure that these long-term effects of giving live bacteria aren't in fact impacting our infants with sepsis and white matter injury and other trends that we're seeing in that group. So it does make me nervous. I have not instituted that practice because of those reasons. I think it definitely needs to be studied more. I like the literature. I didn't talk about it. I'm not sure if Dr. New will, about, well, maybe you don't have to give a live organism. Maybe there's other ways using the microbiome that you can promote these benefits that I discussed about earlier, but concerned in that very low birth weight or extremely low gestational age group.
Do you have the impression that neck occurs in clusters in the neck group?
Yeah, I mean, there's definitely been reports to suggest that it can cluster. I don't think anyone has ever figured out why it may be clustered, whether that actually lends proof to an infectious organism that you just aren't able to identify, or or isolate in the blood. So there's definitely been clustering reports of it. There's also fluctuations from year to year, and we'll talk, I can try to bring this into the neck talk, but I started collecting this biorepository mainly to evaluate neck, and it's been ongoing for about 2 years, and neck seems to almost stopped in our unit. So maybe that's what you need to do, start a biorepository to study it, and it'll go away. So, and why? Our practices really haven't changed. Okay, all right, thank you.